what did Garrison Keeler say at Lake Wobegon? Where everyone is special and good looking and very smart. So I guess I'm supposed to be all those things. So thank you, Lisa, very much. That was incredibly kind. So I am a unicorn, okay? And the reason I'm a unicorn is because I'm a geriatrician, right? So I am a board certified geriatrician. There are a total of 3 geriatricians in the Athens area, compared to, I don't know how many cardiologists or other kinds of specialties there are, but there aren't a whole lot of geriatricians in the world. And for the topic I'm going to talk about today, which is Alzheimer's disease and related dementias, this is one of the things I went to Geriatrics Fellowship to specialize in, was understanding how to take care of people with dementia and Alzheimer's disease. And one of the reasons I did that was because my father had Alzheimer's disease. And he developed it when he was about 80 years old. And so I saw my father, who'd been an attorney and a county judge and, you know, a very well-established person in our little community, go through this disease. And of course, it was heartbreaking. And for many of you who have loved ones with this disease, you know what that's all about. So, but before I get there, every talk is supposed to start with a joke. So can I tell you a joke? All right.
Whoa! I gotta hear this.
You ready?
Go into that.
I'm afraid this is going to feed back.
Try it.
Hello, hello. Can everybody hear me?
Yes.
Okay, so I took my dog to the vet this morning because...
No, can't hear you.
You can't hear me?
No.
Okay, can you hear me now?
Yeah.
Very good. I'm going to use this thing then. So I took my dog to the vet this morning. He ate a whole bag of Scrapple tiles. Can you believe it? So I took him into the vet and I dropped him off. And just before I came to give this talk today, I called the vet to see how he was, and the vet said, "There's no word yet." All right. Okay, so now that you all like me, okay, here we go. All right. So what I'm talking to you about today is sort of going to be a brief tour through Alzheimer's disease and related dementias. And dementia is not called dementia anymore. The American Psychiatric Association, the American Neurologic Association are now recommended to be called major neurocognitive disorder. Because, right, exactly, yeah. So I'm still going to call it dementia, but the reason they did that is because dementia is a word that's kind of pejorative and a little bit, I'm not going to say nasty sounding, but it kind of is. And there's other reasons, but we're going to still refer to it as dementia for right now. So, I'll do my best. You can take a look at the slides there on the sides. So the first thing to tell you is that dementia is not really a specific diagnosis. Dementia is a description of a symptom, and the way it is defined is someone has dementia if their overall cognitive function is not what it should be for someone of their age, and that cognitive function problem is affecting their physical, social, or occupational function. So some of you may have been to the doctor yourself or with a loved one, and they get the memory test, which is often, you know, what week is it, what day is it, what year is it, draw these, you know, interconnecting pentagons and remember these 3 or 4 or 5 words, okay? So that is a screening test for cognitive function. So you basically have to not do well on that, but in addition, you have to have some problem with your physical occupation or social functioning. So to give you an example, I saw a patient recently who was a furniture maker and an artist, and both he and his wife had noticed that in his furniture making, he's taking a lot longer to do things, and he's making more mistakes than he ever did before. And he had some repetitiousness, some repeating of words over and over, but that wasn't the biggest thing that worried them. But they were worried about his thinking. So they came in to see me, and I did one of these memory tests on him. Of course, I took a history and did a physical exam, and we did a memory test. And he didn't do so well on the memory test. He was below the cutoff score for cognitive problems for someone his age, and because this cognitive issue he was having was affecting his ability to carry out his occupation, which was an artist and furniture maker, he was diagnosed with dementia. Now, But that doesn't mean we know for sure what's causing the dementia, okay? So there are 4 major diseases in the United States which cause dementia. And number 1, by far and away, is Alzheimer's disease, okay? The estimates are anywhere from 50 to 80% of all people with dementia in the United States have Alzheimer's disease. Another cause of dementia is Lewy body disease, which is related to Parkinson's, but which is not Parkinson's disease, but it's a cousin of Parkinson's disease. Another cause of dementia is vascular disease, okay? It can be from strokes in the brain, or it can be from what I'll call silent strokes or microvascular disease in the brain. And the last cause of dementia, which is rarer, is called frontotemporal dementia. Now, all of these conditions are causes of dementia. So getting a diagnosis of dementia is not just enough, and making that diagnosis is not just enough. We want to understand what's causing it, okay? So now there are other things that we have to check out that can be causing people to have cognitive problems like medications, like thyroid disease, and I'll talk to you a little more about that. But I just want you to understand what the diagnosis is, what the difference is between dementia and figuring out what its underlying cause is. So the other thing that a lot of folks, including many clinicians, don't understand is that you do not have to have memory problems to have dementia. Okay? To have Alzheimer's disease, yes, you do have to have memory problems, all right? But to have frontotemporal dementia, vascular dementia, or Lewy body dementia, you do not have to have memory problems early in the disease. So there are a lot of other cognitive domains here that can be affected by dementias. And you'll see that some of them are things like language, being able to speak, find words, being able to recognize objects, naming, being able to attend to tasks, being able to attend to a conversation. I will interview patients that are suspected to have dementia, and I'll ask them something like, so can you tell me how you're feeling today? And they start off with talking about how they're feeling today, and pretty soon, we're talking about something else, like what their dog was doing yesterday. So it's difficult for them to attend and to stay on target. Another thing is visual-spatial skills. I'm sure you've all heard about people that have dementia of one form or another going out and getting lost, wandering. You've all heard the news stories about people that have dementia, usually Alzheimer's disease, that wander off and they're just found somewhere and nobody has any idea of where they belong. Well, it's because that person goes out and they get lost and they don't know where they are. And then finally is something called executive function. And so this next part of the slide just says that some dementias do not involve memory at first, and then Alzheimer's dementia does not involve, Alzheimer's does involve dementia learning at first, so that's what I just told you. This executive functioning part of cognition is interesting. It's the little manager that sits up in our head and sort of is the overall manager when we're doing complicated tasks. So multitasking is something that you have to have this executive functioning cognitive ability to do, right? And for some people, it's the reason why I'm, and this, I don't want to scare any of you because everybody does this. But when people do this an awful lot, then it can be a sign. So executive functioning, I'm getting up to go into the refrigerator to get myself a Diet Pepsi, okay? And then I start thinking about, I wonder what I'm doing tomorrow morning. And now I'm in the kitchen, and I don't remember what I'm in the kitchen for. Now, we all do that from time to time. But if you're doing that 4 and 5 and 6 times a day, then that's a different story. So that's an example of executive function. Executive function also allows you to be able to do what's called set switching. So for instance, if you're preparing the spaghetti, you have to think about what's necessary to bring the water to a boil. Then you have to think about what kind of plates you want to get down. You've got to think about what order you want to do those things in. So that's called executive functioning also. And I don't want to belabor the point, but this is something that does go awry early in Alzheimer's disease. But the main point is that there are many different types of thinking or cognitive function that are involved in dementia. It's not just memory and learning. And please, by the way, I want this to be as informal as possible. So if you have a question about anything I say, or if you have a comment, please raise your hand and ask. And can everybody still hear me okay? Good. So these are the 10 warning signs of dementia. And this is from the Alzheimer's Association. So number 1 is memory loss. And I think we're all familiar with that. But one of the ways memory loss will present itself is repetitiousness, okay? This is one of the number 1 symptoms that I hear about all the time, is that mom or dad or my husband or my wife, they're asking me the same questions, 5, 6, 10 times a day, right? They're asking the same questions over and over again. And that's a function because they can't remember, what they've asked, and they're just not keeping track of things. So that's an example. So difficulty performing familiar tasks. That has to do with this executive functioning thing I was talking about. But an example of that is the woodworker I told you about, who can't really do his artisan woodworking in the same way that he used to be able to. Problems with language. This is something that I also see fairly commonly. And I just saw a patient at the care center not more than 3 weeks ago who came in because he was having all these problems finding words. So he would try to say the word mast, M-A-S-T, and he would just get stuck, and I knew what he wanted to say, and then he would say M-A-S-K, mask, right? He couldn't find the word he was looking for, right? So that kind of word finding can be an issue as well. So disorientation to time and place, and if you ever take a memory test, when you go to the doctor's office, they're going to ask you, what is the year, what is the day, what is the date, what kind of place are we in now, what state are we in now? And while these may seem like very simple questions, to someone who's developing dementia or already has it to a fairly severe degree, they won't be able to answer some of those questions, right? And that's more than just memory, it's orientation. Poor or decreased judgment, right? So the scam artists know all about this, all right? They're going to call up people and ask you to, I don't know, donate to some bogus fund. And people with dementia don't have the discriminating power anymore to recognize that this may be a scam or this doesn't sound right. So they'll just write a check for $10,000 and just send it off. And and also on more than one occasion, we have had bank officers contact not only the care center, but also the Athens Community Council on Aging, which I also work with, because they're concerned that this person that they're working with is writing all these huge checks to these, ridiculous sounding organizations, and there must be something wrong. So there can be a problem with judgment. And misplacing things. Now this gets to be, right? So someone's going to raise their hand and say, doesn't that just come with old age, right? So 2 things to say about that. Guess what the number 1 reason why dementia doesn't get diagnosed as early as it should? Because people think it's just old age, okay? Having said that, there are some things that do occur with old age, okay? I got good genes from my mother. Believe it or not, I'm 62. I don't know, maybe I look 62, maybe I don't. I have word finding problems now. So trying to remember, gosh, who was the guy who was in One Flew Over the Cuckoo's Nest? Who was the lead actor? Right. See, the other day that took me like 5 minutes and I couldn't remember it all, and finally I did. Okay. So some of the word retrieval things can occur as you get older, and problems with that, and multitasking can be a problem. All right. But the misplacing things is, if you're misplacing things all the time. I knew that my aunt was developing dementia when literally 20 times a day she was talking about, where's my purse? Where's my purse? Where's my purse? Where's my purse? Okay? Because she was constantly misplacing it and couldn't remember where it was. So the other, I don't want to go through all these. I feel like I'm taking too much time with this because I want you to have a lot of time to ask any questions you want. But the other sign of dementia that a lot of people don't realize can be changes in personality or behavior. All right? And that can occur before memory problems. So, the idea that Mom used to get up every day at 5 o'clock and make the bed, and everything was spotless. And now she's sleeping till 9. She never makes her bed. She isn't showering the same way as she used to, right? And she's getting crappy, okay? Some people just might think that's old age, but more often than not, that can be a sign of dementia, right? As can depression, all right? So these are the kinds of things that I want to emphasize, because dementia is not just memory problems. It's problems in a whole lot of other areas. All right, so I wanted to just show you the pathology of Alzheimer's disease in particular. And if you can see the slides up here, it's great. It's showing you a normal brain on one side, a slice through it, and a brain with Alzheimer's disease on the other side. And for those of you that can see the slides, I think you can tell which is which. And so Alzheimer's disease is a neurodegenerative condition, and basically what that means is death of neurons, the cells of the brain. And when those neurons die, this is what you end up with. You end up with a shrunken or atrophied brain. So this is just a very graphic representation of the picture of what Alzheimer's disease looks like. And again, this is a slide. I apologize if you can't see it, but it's showing you the changes that occur in the brain with Alzheimer's disease, and it's the development of what are called beta amyloid plaques and neurofibrillary tangles. So some of you may have heard of this. Alzheimer's disease is associated with plaques and tangles. And these are structures which basically form because of the pathology of Alzheimer's disease and cause neuronal cell death. Okay? So this, what you're seeing is, on the top is a normal brain. On the bottom is a brain with Alzheimer's, and all those big round orange spots are beta amyloid plaques, okay? And it's going to be difficult for you to see the tangles because they're smaller and within the neuron body itself. But this is what we see in the brains of people that have Alzheimer's disease when they are sectioned and look at under the microscope, okay? Interestingly, this is thought to be right now what causes Alzheimer's, but we are far from understanding why these things form, okay? So we know what Alzheimer's looks like, but we don't know for sure yet what the cause is, what causes these things to happen, okay? So that's that. This is a slide just to show you that Alzheimer's and the related dementias, remember there's vascular and Lewy body and frontotemporal dementia. What you're seeing is a graph that shows you as you move from left to right in the graph, what you're looking at is the aging of the population. So on the left is 65 and over, and all the way to the right are folks, So what you're looking at on the bottom of the graph is time, right? So you're looking at an increase in the population. The yellow are people 80 to 85 and over, and the purple are people 70 and over. So Alzheimer's disease and the other dementias are diseases that get much more common as we age. And right now, there are about 6 million people or so that have Alzheimer's disease and related dementias in the United States, and that's expected to triple by 2050, okay? So this is, conditions are becoming much more common. And in Georgia right now, there are 150,000 people as of 2020 that had Alzheimer's disease. And by 2025, that's expected to increase to 190,000. And that's a 26.7% increase in 5 years. Okay. So Georgia is the sixth fastest growing state for Alzheimer's disease. And this is just Alzheimer's. We're not talking about the other dementias as well. So there's this 37.5% increase in Alzheimer's disease. It's expected to cost Georgia Medicaid $1.3 billion this year. There's going to be an increase in costs by 40% by 2025. Georgians provide 600,000 hours of care for persons with Alzheimer's disease and related dementias, and the value of that is $7.5 billion. And this is not people we pay to take care of those that have dementia, because who really are the people that care for people with dementias and provide their day-to-day care? right? It's family, right? It's family, it's unpaid caregivers, and this is what this statistic is about. And let me just say that, when I take care of people with dementia, as you can well imagine, it's not just the patient that's the patient, it's the patient and the family, and especially the caregiver, because as goes the health of the caregiver, that's how the health of the person with the dementia is going to go as well.
You have a question?
Yes, please.
If Georgia is the 6th state, do you mind telling us what the other 5 are?
If I had that right at the tip of my tongue, I would be happy to tell you, but California is definitely one of them. I think New York State is another one. Florida is one too. It's basically the states that are aging the most rapidly, okay? And that can be either because of people moving in, and I won't ask how many people are new arrivals in this audience to this area, but I bet at least some of you are. So it's people moving in, and then it's younger people moving out. So,
Is there something about the state's environment, generally speaking, that's explanatory?
right. And I have a different slide that shows by state, the states with the fastest growing populations of people with Alzheimer's disease, and Georgia is right up there. So what other couple of states would you suspect, which are probably very like Georgia, that should be right up there too? South Carolina, Florida, don't say Alabama. Sorry, that's just a joke. Yeah. And interestingly enough, so call the whatever you want, the Southeast, the Bible Belt, the Barbecue Belt, call it whatever you want. But those are not, the other states like Alabama, Mississippi, and South Carolina are not increasing as quickly as we are. So the answer to your question, I'm not sure, is known. If anyone else that's sitting in the audience, because we have some very distinguished scholars in the audience, has an idea about that, I would be happy to hear it. Right, but why is Georgia increasing faster? And I don't think it's because of reporting. So I don't think Georgia has any better reporting necessarily than Florida or Alabama. Maybe we got better reporting than Mississippi, right? Maybe we're keeping track better. But I don't know the answer to that question.
I'll ask one question.
Yes,
to help with
please.
interpretation. So when you say the speed, that is based on percentage of population?
That's
and
correct.
Not numbers?
Yes, the percent of population, right?
That's
Yeah. So in terms of how fast things are increasing, when you look at what's going to be the projection for the percent of population that will have these kinds of diseases in the future, that's what we're talking about, is the percentage. What were those things your mother always told you to do? And those are the risk factors. What are we supposed to do? Eat right. Right. Exercise. What's that? Spinach. Eat your spinach. Right? Right? So be involved socially. Okay? Get enough sleep. Right? So these are some of the established risk factors. Physical inactivity, smoking, excessive alcohol consumption, head injury, infrequent social contact, obesity, hypertension, diabetes, depression, hearing impairment. And it's interesting, there's a great deal more evidence that has emerged over the last at least 2 to 3 decades of how closely linked cardiovascular risk factors are to Alzheimer's disease. So one of the things that we always really try to emphasize at the care center for people that do have hypertension, diabetes, hypercholesterolemia is how important it is to tightly control those conditions. And head injury is an interesting one. So you've all probably have heard about the football players that get multiple concussions, and there's something called chronic traumatic encephalopathy, CTE. And that's from repeated head injury. And it is a form of dementia. Muhammad Ali, we saw what happened to him, right? He probably had CTE. One of the things I always ask people when they come in to be evaluated is about a history of head injury. And I've had more than one older man that used to be a boxer, okay? So these are the things, you go to geriatric fellowship to learn about. These are the kinds of questions you need to ask that not every doctor might think about. So, you're concerned that your loved one may have dementia. What should you do? So, or you're concerned you may have it yourself. right? I'm getting worried. My father had Alzheimer's disease, okay? Is there an increased risk that I'm going to get Alzheimer's disease? Yes, there is. Now, it doesn't mean I'm going to get it, okay? But I may. So believe me, when I can't think of Jack Nicholson's name for 5 minutes, when I'm trying to think of who, you know what I'm saying? And some of you may have had these same feelings and thoughts. So if you want to get checked out, you go to your PCP. You say, I'm concerned that my thinking is blank, not right, off, just I'm in a fog, whatever it is, okay? Or you can say, I'm concerned I may be developing dementia. And then you say, why? Okay? Can you give me, and you call it whatever you want, can you give me a test for dementia? Can you give me a cognitive test? Can you give me a memory test to see, excuse me, if there's something wrong? Okay? If not tested, okay, if your doctor just kind of blows you off and says, well, that's just old age, you don't really need to worry about that or whatever, say, yeah, but you know, Doc, I am really worried about that, so could you send me to a specialist? Okay? You could ask for a geriatrician, for instance. And you could ask to go to the care center. And by the way, I make no money, I've got no financial investment, I'm not here to, so.
I'm not going over this.
Yeah. And at some point, if you don't get what you need to be tested cognitively, you just need to go elsewhere, okay? But almost any PCP is going to take this seriously and test you. But don't accept, and especially when you're bringing a loved one in, don't accept the idea that, everything's okay, it's just age. Don't ever accept that as an answer from a clinician or an NP or a PA or whoever it is you're seeing, okay? So then the question becomes, well, why don't we screen everybody 65 and over every year to see if they may be developing dementia, cognitive impairment? And the problem is that there are a lot of criteria that have to be met for a screening test to be useful. And a screening test means you're testing someone who is asymptomatic to see if they have a problem, a particular problem. In addition to that, it has to be prevalent enough in the population. In addition to that, there has to be really something that you can do about it that's cost effective and so on and so forth. So two of the most important organizations in the United States, which is the United States Preventative Service Task Force and the American Academy of Family Practice, along with the American College of Physicians, does not believe enough screening criteria are met yet to make these cognitive tests good for screening everybody every year, 65 and over, all right? However, so you may be wondering, well, I've gone to my primary care doctor, why have I never been, checked to see how my cognition is? It's because it's not recommended by a lot of these major organizations, but who it is recommended by is the American Academy of Neurology and the American Geriatric Society. And what you typically will find when you go to specialty societies that deal with specific problems, like if you go to a cardiologist, cardiologists are going to will usually be a lot more aggressive about screening for certain things and treating certain things than just a general practitioner will. That doesn't mean one is right or one is wrong, but it's just that specialists tend to be more aggressive. So I do screen all of the patients that I have who are 65 and over for dementia, and of course that's all my patients, and I screen every year, okay? So, how many people here have been to a Medicare, welcome to Medicare visit or a Medicare annual wellness visit? Right, so everybody. How many people here have had a memory test when you went and did that? Right, okay, so your Medicare annual wellness visit does require that you be screened for cognitive impairment, okay? There's different ways that can be done, but somebody should be asking you things relevant to your memory. So how do we diagnose this disease? So it's a clinical diagnosis, right? What does that mean? It means there is no single test. There's not a blood test, a brain scan, a biopsy. There's nothing that definitively can say you have Alzheimer's disease. For some of the other related dementias there are rather, but I do want to focus just on Alzheimer's disease for right now. So then how do we diagnose it if there's not a biopsy, if there's not a particular exact objective test we can order? So the way you do it is it's diagnosed on symptoms. It's diagnosed by what's the story of those symptoms, how have they progressed or not, and how is it affecting your function. Then you have to have a physical exam, okay? And the physical exam should really focus on the neurological exam. And then you get cognitive testing. And what you see up on the slide is something called the Montreal Cognitive Assessment Instrument. It takes about 15 minutes to do, and it is the most sensitive test for detecting cognitive impairment in people 65 and over. Okay? So there is a test. Now, but that doesn't mean you have dementia. You can have cognitive impairment, but unless it affects your function, okay, you don't have dementia, because dementia has to affect functioning. Then we have to exclude other possible diagnoses, things like depression, medication side effects, hypothyroidism. There are several that need to be excluded. And how do we do that? We do it with lab tests. And when I was in training, it was not recommended that everybody get a brain MRI who one suspected of having dementia. It is now recommended, however, because the MRI technology has advanced to the point where it is much, much more detailed, and we can tell a whole lot more than we used to be able to, not only about the structure and the function of the brain, and PET scanning can be part of that too. So I'll make these slides available in some, I'm sorry, yes, sir.
Where in the testing can you distinguish between depression and Alzheimer's?
Yeah, so that's a very good question, because certainly those conditions can coexist, number one. And number two, so I'm sorry, how can you distinguish between a dementia and depression? Okay? And what I said was they can coexist, so that's the first thing. But the second thing is that someone with depression, their cognition can be affected, a little bit, or even a moderate bit, but not a whole lot. Okay, so major depression can be the type of the depression, the most serious depression that can really knock someone's cognitive functioning down. But if it goes down below a certain level, then it's unlikely to be just depression alone. So that's the first thing I'd say. The second thing I would say is that there are symptoms that occur in depression that don't necessarily occur in these dementias. But the final and most important thing is there's something called neuropsychological testing, all right? And these are very detailed tests of memory, of your emotional health, of a variety of other factors. Thank you very much. Lisa's a neuroscientist, and she's also trained in how to do these, what are called neuropsychological tests. So to answer your question, if I've got a real question in my mind, as the geriatrician, as the MD doctor, about whether this is something like Alzheimer's disease or is it more likely to be depression, I send folks on for this more detailed neuropsychological testing battery to try to sort those things out. But depression is always high up on the list of things that we want to take into account of whether or not it may be causing some of the cognitive impairment we're seeing. And I was told to go to 15 after, and it's 15 after. Can I beg your indulgence? I just want to tell you one more thing, and it's about treatment, okay? So the first thing I want to say to you is treatment is not just pills. The most important part of what I do in treating people with dementia has nothing to do with pills. It has to do with patient, family, caregiver education, okay, about what the disease is, how it's likely to affect people, and strategies for working with your loved one to reduce stress. As some of these dementias, actually as all of them advance, what can happen is people may not recognize someone anymore, your loved one, as your son or whoever your loved one may be. And so instead of always trying to convince that person, hey, I'm not your brother, I'm your son, right? The thing that you might want to do is kind of go with the flow with them, all right? So these are the kinds of things that folks need to be educated about. Support is extremely important because the health of people who are primary caregivers can be very much affected by their caregiving roles. And so they need support, they need emotional support, they need medical support. There needs to be education given about home safety, right? So the idea that you might want to put covers on the stove if you have a gas stove, so people can't accidentally leave a pot on and burn the house down. I had a patient in my geriatrics clinic that came to me a year ago, and the reason he was in Athens now is because he burned his house down in Florida accidentally because he left a pot on the stove. So I'm talking safety, I'm talking about those kinds of things. So the medicines we have now, I can sum it up by telling you this. The medicines are of two different types. There's the medicines that are called cholinesterase inhibitors, that's Aricept, Exelon, and Razidine, okay? And they can do a little bit of good for a short amount of time, but they are in no way magic bullets, and some people don't get any benefit from them at all. Others do get some benefit. In research trials, they've been shown overall to help a little bit. Memantine is the other class of drug we have, and it's for people that have more moderate to advanced types of dementia. But without going into further details about this, if you go to your physician, okay, and you say, I'm thinking I'm having memory problems, or I think my husband's having memory problems, and they just hand you a pill, here, take this Aricept, okay? That is not state-of-the-art medical care, okay? State-of-the-art medical care is, first of all, does your husband or loved one or whoever it is, do they really have dementia? And then, what is causing it? Because not all pills are effective for all the causes of dementia. Okay, and I can't emphasize that strongly enough. So you always want to ask, exactly why are you giving me this pill? And the pills can have side effects. So having said that, let me just stop because I've talked a long time. And does anyone have any questions? Yes, ma'am.
It seems like I heard there was a blood test at least to determine an initial level.
So I can tell you the things that I know about. I'm sorry. So the question was, she had heard that there's a blood test that can give a lot more information than perhaps in the past. We didn't have such a blood test. There may be, and I may be, unaware of it. What I will tell you in terms of the frontiers on diagnosis is that, number one, doing certain kinds of PET scans and MRIs are gaining much more credibility in terms of being able to really objectively diagnose. It's not ready for prime time yet, but measuring the actual size and volume of certain structures in the brain that are affected by the different dementias, that's one thing that's being looked at. Using PET scans, which can actually show you not just the anatomy, it can show you what's going on functionally in that area, like how much glucose is being used in that area. That's a big frontier now. And the other thing, and you're not going to like it, and I don't like it either, is the analysis of cerebrospinal fluid. Because to get that, you have to have a lumbar puncture, which is otherwise known as a spinal tap. And they measure the levels of some of those nasty things I showed you in the brain, beta amyloid and what's called tau protein. So they can do that, and it can contribute to a diagnosis, but it can't make exactly the diagnosis yet. But this is probably the area that's in most rapid evolution right now in terms of improving, is the area of improving our ability to make an objective diagnosis. But here's one thing I can tell you about Alzheimer's disease and all of these other ones, except for vascular dementia, they progress. And so there's always the test of time, because if I think you have Alzheimer's disease today, and a year from now or 2 years from now, you're no different and just the same, it's very unlikely that I was correct, because the diseases are progressive. So the test of time is often what we use too. Yes, ma'am?
Are you saying vascular dementia does not progress?
It may not progress, because if you are not accumulating a lot more in the way of strokes or in the way of this microvascular disease, which means the little blood vessels getting clogged up, and you're really controlling your blood pressure, your diabetes, and your lipid disorders, cholesterol if you have them, it may not progress. I saw a patient not too long ago who came in. She thought she had Alzheimer's disease, and we were talking, and her husband was with her, and we talked about how were things about 5 years ago, and she said, and he said, well, things aren't really that much different. I mean, it's not good, but it's not that much different, okay? So I started to doubt the diagnosis, and then I did a functional MRI on her, and it showed she had all this microvascular disease in her brain. And so that's important, because I could say, let's really, really control all these risk factors that are causing you to have this microvascular disease. And it may be that this is not going to progress. So that was important for them to hear also. Okay. Oh, one more. Thank you. Yes. Right. And so just the go with the flow thing I was talking about specifically was about when people are not grounded in reality. So if my mom thinks I'm her brother, or if, you know, my mom thinks it's time to go to the her sorority meeting or something like that. So it's a very, very complex and complicated question, the one that you just asked. So one of the reasons we started the Care Center was to answer that question, was to help provide education and support and resources of where to find that education and support. And if you didn't hear the question was, I'm sorry to repeat it, the question was, as a caregiver for someone that has a dementia, as things are getting worse, you know, what can I really do to be able to help them? What other strategies are there? And so, of course, the Alzheimer's Association, I want to emphasize this too, the Alzheimer's Association is not just for Alzheimer's disease. It's for any of these forms of dementia where there are a wealth of resources. So things that you can read online and pamphlets. You know, one of the things that I hear about all the time, and one of the difficult to manage behaviors is, you know, if someone's becoming paranoid, okay, and thinking things like someone's trying to poison me, or, you know, my husband's having an affair with the woman who lives next door, all kinds of delusions and unusual ideas. So for some things there can be medications, but you need somebody that's really expert in working with that. And then the most important thing that I found for families are Alzheimer's support groups. So going and talking to other caregivers that have been through the same thing that you're going through. I have learned all kinds of tips and tricks from going to Alzheimer's support groups that I can pass on to families. One of the ones I heard just last month at an Alzheimer's support group meeting is never be the first one. Never get out of the elevator ahead of your loved one with dementia. Because guess what happened to this person? They got out of the elevator ahead of their loved one with dementia. The doors closed. And they were in like a 20-story building. And so, right, you know, that's the thing I would never have thought about, but it happened with these people. And so, you know, these sort of tips and tricks. And I don't know whether Lisa or Janae want to say any more about this, about helping caregivers plan with, you know, education, support, that kind of thing. It's just a huge question. Oh, I'm sorry. Yes, sir.
For those in the audience, don't take lightly what he said about the elevator. I was in the Atlanta airport. My wife of now 15 years of Alzheimer's experience, since she has been identified. Somehow, over the year,
Let me pass the mic. Could you repeat this, please,
Yes.
sir? Just sort of.
I said, don't take lightly what Don said about the elevator story. Don't leave your loved one behind. My wife has had Alzheimer's for many years. And about the middle of her, I say active life, but the minute of the time we could travel together, even with the Alzheimer's, I grabbed her hand, hopefully in a loving way, but the doors were shutting on the tram. And she immediately yanked yanked my hand away, and the doors are shut. I spent 2.5 hours at the Atlanta airport searching for her. We found her just wandering around, happy as could be. I wasn't worried about me at all, but I will tell you that that's realistic. When you turn your back on them or get them out of your sight, don't do it. It's bad.
Yeah.
One other question I'd like to ask you.
Sure.
She's been on Aricept. I know we kind of pushed off the medical part of the detail on Aricept and Namenda for years. And we don't think it helps at all. I'm fairly comfortable. Are there negative effects if we go to the MD and say, get rid of them?
He's probably going to have to make he or she will probably have to make she will have to make a decision that she may or may not, know the data about. So that's the first thing. The studies with these medicines, there's never been a study that goes for more than about 2.5 or 3 years. So we don't know for sure beyond that whether they really help or not. And one of my I think, biggest talents as a geriatrician is to help stop medicine and not start medicine. And so what I can tell you is that, so they have side effects. The biggest side effects are either GI side effects, and with Aricept particularly, having very vivid dreams and having insomnia. So probably none of that is going on, because if it was, it may have already been recognized. But if someone is advancing and getting worse on the medication, then it's always worth a trial of cutting it back. Let's see if there's a difference. And this is what I teach the residents and the medical students, just about deprescribing medicines in general, is, okay, well, we don't know whether it's doing anything anymore. Let's decrease the dose. Okay, are things the same? Are they worse? Well, if they're worse, let's get it back. But if they're the same, let's decrease it some more. So a trial of tapering off those medicines is the way to go. But the patients that I take care of in the memory center at Highland Hills, almost all of them come in on both Namenda plus one of the other ones like Aricept, and they've been on them for years. And so I talk to the families, especially if they're progressing or if someone has reached a really advanced stage, about let's think about cutting back on these, because they are also very expensive. They can be. There's a patch called the Exelon patch. It costs, it's like $600 a month. Now that's the total cost, and insurance is going to cover part of that. But yeah, so that's what I'd say. Yes, ma'am.
Our very wonderful tech teacher, Bess, has told us that there's an excellent way to keep track of someone who might wander, and that's an AirTag. Pop that in their pocket. You have your phone, and you'll know if they're lost.
That is a great idea. I've had families also who they're always sure that their person has an iPhone or some kind of phone that, right, they can't use it, but what you can do is there's a setting on some of these devices where you can see where they actually are. And parents love this, of course, but what you're talking about, I'm not sure what an AirTag is, but...
It's a tiny button.
Yeah.
You can buy 1 or 4, put out by Apple, and it meshes with your phone, and you can put it in your purse or your car or your lost one. And if you lose them, your Find My app on your phone will find it.
Yeah, and that's great. And that's why I love going to Alzheimer's support groups and doing community presentations like this, because you just taught me something.
Can you give a mic we can't hear him back?
Yeah, so what she's talking about is for people that wander. So some people that have Alzheimer's and other dementias can wander and get lost. And there's a little device called an AirTag, okay, that's apparently made by Apple, that works with the cell phone. And you put this little electronic device, that's what, as big as a quarter, you put it in that person's pocket and you can see where they are at any time. So if they take off on the train accidentally, you can figure out where they are. The other thing I want to say is that the Alzheimer's Association has something called the Safe Return Program, which is basically the person has a first alert bracelet on, okay? And if they are found out in the community, they wander out and they're found by the police or somebody else, it says call this number. And they, because what often happens, and I've seen this happen, it actually happened to my father as well, unfortunately, is he was out, he was wandering, he was confused, and unfortunately he was driving and the police stopped him. And guess what they thought? He was drunk. Right. So he ended up going through all this, going to the police station, being booked, and right. So it's called Safe Return Program from the Alzheimer's Association. Yeah.
I have a quick comment about that Apple AirTag.
Yes.
They make it so it's actually a part of a person's keychain. And often you have your keys with you on your pocket or in your purse, and so that is a really handy device. Another tech kind of solution or something to think about. In your phone, make sure you have in case of emergency in your contacts. If you are somewhere where someone's looking for who do I call, I don't even know what to click on in the person's contacts in their phone, they might look for in case of emergency or ICE, I-C-E. So just something for y'all to think about in terms of safety.
Right, and what Dr. Bear is saying is that this little thing called an AirTag, you can be part of a keychain that people will wear. And by the way, any phone that you have where you can put in contacts, there will be, when you put the contact in, there'll be a selection. Do you want this person to be an emergency contact? And if you select that, then the person is an emergency contact, which means if the police or whoever find the person, you know, if they're unconscious, if they're wandering, they know to look in the phone and look for the emergency contact. But you have to set that as a setting when you put in that person who is the contact. And I just found that out like 2 years ago. So, go figure. Yes, ma'am. You look familiar. It's nice to see you.
You too. I have a question. Someone asked about how do you know that your loved one or the person that has Alzheimer's is progressing? You know, how do you know that the disease is progressing? And I have had my husband for 5 years, have taken care of him. I could tell you when it started progressing, each step. You know, there were just certain signs, and although I was with him every day and watched his every move, I saw signs that I didn't see maybe a month or so ago. You know, like he lost control of his bodily functions and things like that. So believe me, if you're a caretaker and you have been for so many years, you know what the progressions are.
Yes, and thank you very much for that. And that's why when a person is being assessed to find out if they have dementia or we're looking at is the person progressing, the most important person to talk to is the closest family member, caregiver who lives with them every day. Because as you may know, there are a whole lot of people, especially with early disease, they ain't got no problems at all if you ask them. Everything is just fine. Right, and you got to talk to the family, and they'll deny it, and then that gets to be very difficult. Yeah. All right. Well, thank you very much. It's a privilege and an honor to speak to you. Thank you.